Okay, so why don't we go ahead and get started today? So today I'm going to talk about some of the recent advances in cardiac magnetic resonance and talk about where the future may be going. So here's kind of the outline of my talk for today. So I'm going to talk a little bit about myocardial replacement fibrosis and how it's recently been shown to provide additional insights into both valvular heart disease as well as cardiomyopathy. Talk about some technical improvements in the late gadolinium enhancement technique. Talk about some recent studies looking at myocardial tissue composition in valve disease. And then wrap up with some advances in stress CMR, both from the standpoint of application, but also from the standpoint of technological improvement. And some of the ways that are being utilized to try to accelerate the speed of imaging. So let's start off. I think, does everybody know who this guy is here? For the fellows, who is this? Valentin Fuster. So obviously he's a giant in the field. And so I thought, okay, if I'm going to look at what are the recent advances in cardiology and in cardiac MR, I thought, well, here's a gentleman who does a podcast every week of all the articles that are published in JACC. And interestingly, at the end of the year, he actually went through and picked his top 100 publications. So I thought, well, this is a great starting place. And so several of the studies that I'm going to highlight here are actually from this article from Dr. Fuster of the top picks from 2018. So in fact, actually one of them was a study that was done here last year looking at myocardial fibrosis in patients with mitral valve prolapse. And so, here's an example of a patient referred to the CMR lab with mitral valve prolapse, and the question here was severity of mitral regurgitation. Obviously, we can see a signal void here in the left atrium. We can also see that there is some prolapsing of the leaflets. And what's interesting, though, is when we look closely at these cases, you'll notice there's a few interesting kind of peculiar findings. One is that the lateral wall is actually a bit hyperdynamic, the basolateral wall. And in addition to that, let's keep going forward here. If you look at the papillary muscles, normally the papillary muscle should actually descend down towards the apex. And in this case, the papillary muscle actually is going backwards. It's actually pulled up by this prolapsing valve. And so this is what prompted us to do a study where we looked systematically at patients that were referred for CMR. One of the things that we had noticed in the early days was that these patients, for some reason, seemed to have fibrosis, hyperenhancement in this infralateral wall. But we wanted to really kind of characterize this thoroughly. So we looked at a series of about 350 patients with primary mitral regurgitation, and we tried to exclude other confounding causes of fibrosis within the left ventricle. And then we're really left with about 180 patients in each group, those with prolapse, as well as those with primary MR without mitral valve prolapse. And we went through and systematically kind of characterized the presence and location of scar or fibrosis in these patients. And what we noticed was, in fact, that there's these heat maps show, in fact, in the prolapse group on the left-hand side, there's a high prevalence of scar, and it's specifically in these areas right here, the infralateral wall at the base and the mid, and the inferior wall at the base as well. So really, areas that are adjacent to that posterior medial pap muscle, but in the non-prolapse group, in fact, there was no specific area where there was a predilection for the development of myocardial fibrosis or scar. And in fact, aggregate data here, stratified by severity of mitral regurgitation, in fact, does show that there's an increasing prevalence of fibrosis in patients with prolapse that's related to severity of mitral regurgitation. So as there's increasing MR severity in the prolapse group, there's a higher likelihood that they'll have fibrosis present. In fact, with those patients with severe MR, almost half of them had evidence of myocardial fibrosis, whereas in the non-prolapse group, which is shown here in red, the prevalence was low and it was really not related specifically to severity of mitral regurgitation. And then on multivariate analysis, really the only factor that was strongly associated, independently associated with mitral regurgitation or with fibrosis was in fact the presence of mitral valve prolapse. And then lastly, when we followed these patients up for arrhythmic events, we found that those patients with prolapse and evidence of LGE on CMR, suggesting that they have scar, were the patients that had the highest likelihood of arrhythmic events. So this use of late gadolinium enhancement has also been applied to patients with aortic stenosis. And this is a very nice study that was published in Circulation last year, looked at a series of almost 700 patients at European centers that presented for CMR for assessment of aortic stenosis. And they looked at those patients who had severe AS and went on to get surgery. And the objective was to say, does the presence of fibrosis that we see by CMR, is that associated with adverse outcome in these patients after they get aortic valve replacement? And what they found, obviously, was there's two patterns of fibrosis that occur. One is the classic infarct pattern, as you see on the patient on the left-hand side, where it's subendocardial based and then extending outward. And then there's also this more patchy non-coronary pattern of enhancement that can also occur in these patients with aortic stenosis. And what they found was when they looked at either an endpoint of all-cause mortality or specifically focusing on cardiovascular mortality, the presence of late gadolinium enhancement was associated with a worse prognosis than the absence of late gadolinium enhancement. And again, these are patients with AS who are undergoing aortic valve replacement. So despite the fact that you've replaced their stenotic aortic valve, if they have evidence of myocardial fibrosis, the prognosis in the ensuing years is worse. What's also interesting is that when they looked at those patients that underwent valve replacement with SAVR versus those that underwent with TAVR, the prognostic value of the presence of late gadolinium enhancement held true. And in fact, as we would have expected, the TAVR patients overall had lower survival, and that's in fact due to likely to the fact that these are mainly higher risk individuals that are going on to get TAVR as opposed to SAVR. And also what they looked at was to say, is there a differential prognostic implication between infarct pattern LGE versus that non-coronary or non-ischemic pattern LGE that I showed you as well? And in fact, really, the prognostic implication was similar for both patterns of late gadolinium enhancement. Let's move on. This is another, what I call a Fuster favorite. This was one of the studies that he highlighted in his top 100 from 2018. And the idea here was patients with Chagas disease. We don't see a whole lot of those here. I think they're much more prevalent, obviously, in South America. But this is a group of patients that's also been found to have evidence of myocardial fibrosis as manifested by late gadolinium enhancement. And in fact, they have very differing patterns. Some may have a transmural, some may have a very focal extent, some may have much more diffuse or mid-myocardial fibrosis, and some have evidence of apical fibrosis. And in this particular issue, I think it was around August of last year, they published two studies in JACC, which both looked at the prognostic implications of late gadolinium enhancement in patients with Chagas disease. And in the study on the left-hand side was 140 patients. Prevalence of LGE was about 70%. And the endpoint they looked at was CV death and sustained VT. And again, having LGE is associated with a worse prognosis. On the right-hand side, the accompanying study, 130 patients, and this is a typo here, the prevalence of LGE in this study was a little bit lower, it was about 60%. They looked at a composite endpoint, and again, they found that whether you look at the composite endpoint or all-cause mortality, the presence of fibrosis as manifested by late gadolinium enhancement was associated with adverse outcome in patients with Chagas disease. There's also another cardiomyopathy that was studied last year, and this was also listed as one of the Fuster favorites, and this was hypertrophic cardiomyopathy. And in this study, this was from the Cleveland Clinic, they looked at a series of about 1,500 patients who presented for CMR with hypertrophic cardiomyopathy, and also stratified them whether they had obstructive features or not based on echocardiographic findings. And what they found really was that for the entire cohort or specific subgroups, this threshold of about 15% LGE was associated with an increase in risk of composite events. And that's a number that's also been demonstrated in a prior study from about 4 or 5 years ago that was also about 1,500 patients in a multi-center fashion. So it seems to me that this is the extent of fibrosis in hypertrophic cardiomyopathy that's associated with a worse prognosis. And what they found, in fact, also was that it really didn't matter whether it was in the obstructive group or in the non-obstructive group, there was prognostic implications of late gadolinium enhancement either way. And then this was a study that actually just came out earlier this year. And this was an interesting study looking at patients that present with a non-ST elevation MI. And all of these patients underwent a CMR before they went to the cath lab for coronary angiography. And what they found was at the time of cath, about 2/3 of patients had what the operator thought was an identifiable infarct-related artery, but a little more than a third at the time of cath, no one was able to identify a specific infarct-related artery. What's interesting is when they go back and compare to what the delayed enhancement findings before the cath showed, in fact, the same infarct-related artery was only identified as evidence of infarct on the CMR in 41% of cases. So in a significant number of cases, it turned out that there was either a different infarct-related artery or an infarct-related artery was identifiable by CMR that was not identifiable by cath, or in about 15% of patients, CMR actually provided a new or alternative diagnosis. In addition, last year, there's also been an update to the Lake Louise criteria, and to some extent, I think they've actually become simplified. And I think it really, I think what the authors of this writing committee kind of highlight is the fact that the main criteria is really going to be the evidence of myocardial injury, and that can either be traditionally by late gadolinium enhancement is probably the best way to identify myocardial injury, but you could also look at things like ECV and abnormal T1 mapping. That, coupled with abnormalities on T2 imaging, either by T2 mapping or by T2 spin echo weighted imaging, is the most specific for indicating myocardial inflammation or myocarditis. But they went on to say that oftentimes one single feature may be more sensitive, especially if you have other supporting findings such as pericarditis or systolic LV dysfunction. So I think these Lake Louise criteria, I think, for myocarditis continue to be evolving over time. Another technological advance, I think, was the advent of a new technique called dark blood delayed enhancement. So if you look at the images that I'm showing you here, most delayed enhancement imaging is done where, about 10 minutes after the administration of gadolinium contrast, and in that case, the blood pool is bright, but the infarct should hyper-enhance a little bit more than the blood pool, and obviously the myocardium is nulled or suppressed, so it should appear black. And in most cases, this technique is fairly easily able to identify the presence of myocardial infarction, but there's some scenarios where there may be a little bit of ambiguity, and some of it has to do with when the blood pool is very, very bright. So you notice in the early days when we were doing these as research studies, time was really not an issue, and so we would typically wait about 15 to 20 minutes before we start doing our delayed enhancement imaging from the time we give gadolinium contrast. Obviously now, as the technique has evolved, and as it's part of kind of mainstream cardiac MR, there's a push to try to do the imaging faster, and we don't want to be sitting around for 20 minutes. And so that's where you have situations where the blood pool can be very bright. And on the right-hand side, two images, it's hard to be certain whether or not there's evidence of myocardial infarction present. Now, with the advent of this dark blood delayed enhancement, it makes it much simpler because now you've actually got a dark blood pool, so you really suppress the blood pool signal. So this is there's a couple of new sequences that both achieve this objective, but it allows the ability now to really have a much better contrast between the infarct and the blood cavity. So on these examples on the right-hand side, where it was not so clear on the standard delayed enhancement now, this new dark blood delayed enhancement, in fact, makes it very apparent that there's evidence of myocardial infarction that's present. And in this particular study that was published in JACC Imaging last year, this correlated fairly well with histologic findings in an animal model where infarcts were created in dogs and pigs. Here's an example case that I'll show you. And again, if you look at the standard bright blood delayed enhancement, it's hard to be certain that there's evidence of late gadolinium enhancement. But when you look at the dark blood delayed enhancement, it becomes very apparent that there's an infarct here in the infraseptum inferior wall corresponding to right coronary distribution. And then by histopathology, again, this was an example of an animal where the right coronary artery was ligated. And in fact, when they looked at the findings, if you look at the right-hand side, this is the kind of traditional bright blood delayed enhancement compared to histopathology with a fairly tight correlation. But in fact, infarct size by the dark blood delayed enhancement demonstrated actually slightly better. correlation. And when you look at the Bland-Altman plots to look at the limits of agreement, they improved actually somewhat from the standard bright blood delayed enhancement technique. And then in this particular study was also applied in patients that presented with myocardial infarction, evidence of elevated troponins or EKG changes. And in fact, they found that, again, as expected in many patients, the standard bright blood was able to identify the infarct, but in some cases where there's ambiguity, the use of this dark blood delayed enhancement further aided in identification of myocardial infarction. And then lastly, I think one area where this technique could be very helpful also is in looking at the papillary muscles, because that's been traditionally the one area where it's hard by standard delayed enhancement because the blood pool is bright and you're trying to find evidence of a bright or infarcted papillary muscle. But with this technique, with a dark blood pool, it makes it much more readily apparent to be able to identify papillary muscle infarction. Let's move on now to some other areas recently highlighted. And these are a couple of studies that I pulled from the JACC Imaging editorial from the editor of JACC Imaging, Dr. Chandrasekhar, who highlighted some of the studies of interest in cardiac MRI over the last year. So one of these obviously is in patients with aortic stenosis, as we now are having alternative therapies besides surgery. There's become a more and more interest in being able to really study the myocardium and the effects of the stenotic aortic valve on the myocardium itself. So this study that came out of a group in England applied both the late gadolinium enhancement CMR technique as well as the T1 mapping technique that we use to measure extracellular volume. And what they really kind of characterized was three groups of patients: those who had no evidence of LGE and who had what they defined as normal index DCV, which is really just a marker of the total amount of extracellular volume within somebody's heart. And it's basically the ECV fraction multiplied by the left ventricular mass. They found a second group, which were patients who had no evidence of overt late gadolinium enhancement, but they did have evidence of what they described as indexed extracellular matrix volume, an indexed IECV of greater than 22.5. And this cutoff was derived from studying a series of normals at their center. And then lastly, the third group of patients who had evidence of overt replacement fibrosis as seen on late gadolinium enhancement, CMR. And they, in fact, for some of those patients that went on to surgery, they were able to get biopsy specimens from these patients. And they found, in fact, there was a fairly good relationship, again, small numbers of patients, based on the fibrosis by histopathology at the time of biopsy compared to the indexed extracellular volume as determined by the CMR technique. And then, I think, interestingly, they also found when they looked at outcomes, specifically looking at all-cause mortality, they did find, in fact, that there was an incremental worsening of prognosis compared to those with AS and normal myocardium. Those with just expansion of the extracellular volume did worse, and then those with evidence of overt replacement fibrosis did progressively worse than that. And then I think around the same time of this study, there was another study from a different European group which looked at, well, what happens to the myocardium after aortic valve surgery, after aortic valve replacement. And so, and they postulated really that there's two compartments within the myocardium. There's obviously the myocyte or the cell volume, and then there's the extracellular volume. And most of the fibrosis that's going to occur is going to be in the extracellular volume or the extracellular space. The myocyte itself obviously is not going to have fibrosis within it. And they hypothesized that there could be three different patterns of reverse remodeling that could occur. One is where the myocytes do not shrink, so there's not a reduction in myocyte hypertrophy, but rather there's simply a reduction in the extracellular space, in which case the ECV would actually go down. A second scenario where there's actually predominantly cellular regression, but no significant change in the extracellular matrix, in which case the ECV would actually go up. And then a third scenario where you have both, a combination of cellular and matrix regression, in which case you may expect the ECV to stay fairly common or fairly unchanged. And they said now that with the ability to be able to visualize and image both of these separate compartments, let's take a look at what happens to patients with aortic stenosis after they undergo aortic valve replacement. And what they found, compared to the pre-AVR CMR and the post-AVR CMR, obviously there was an increase in or decrease in LV mass to the tune of about 19% in this cohort of about 150 patients. They in fact showed that the extracellular volume fraction, the ECV fraction, actually went up slightly from 28.2 to 29.9. But that this change right here was driven by these two bottom slides, which is that the cell volume or the myocyte hypertrophy actually regressed by about 22% within this cohort, whereas the matrix volume only regressed by about 16% within this cohort. So essentially, you have a reduction in the myocyte hypertrophy much faster than you do in the reduction in the matrix volume. And what's interesting is when you go back and pull some of the old studies from the valve literature, there actually is these findings are not really that surprising when you look at older studies, again, with much smaller sample sizes. This was a study where they did biopsy on patients with severe aortic stenosis, both before surgery as well as after surgery. And in this case, the time intervals they were doing it at was within a couple of years and then within about 6 or 7 years, so very, very late post-AVR. And what they did find, in fact, if I show you the next slide here, was that when they looked at the total fibrous content, again, the total amount of extracellular volume, or the amount that could house fibrosis, what they found compared to pre-op findings, there actually was an initial increase in fibrous content early post-op, but then a significant regression almost close to what the level they found in controls was, but it took really many, many years to achieve that full regression. So suggesting, in fact, that the myocyte hypertrophy may regress fairly quickly, but the extracellular matrix turnover and the reduction in fibrosis may take a much longer time to occur. Now, let's move on to stress CMR. So this was a study that just came out really just a couple months ago. And this was a large multi-center study of almost 10,000 patients that underwent a clinically indicated stress CMR and then were followed for clinical outcomes. And because of the large sample size, the total number of outcomes here and long duration of follow-up, there were almost 1,500 cardiovascular death, or total death, I'm sorry, that occurred within this cohort. And what was found here was really that the presence of ischemia by stress CMR was associated with a worse prognosis compared to the absence of ischemia by stress CMR in this very large cohort of patients. And then because of the large sample size, it allowed the ability to look at very specific subgroups as well. Those with no history of CAD versus those with a history of CAD based on LV ejection fraction, based on whether or not they had evidence of myocardial infarction on the index CMR, whether or not they had typical chest pain, and across all parameters, having an abnormal stress CMR was associated with a worse prognosis. And so I think the authors then conclude that this clinical validation of stress CMR as far as association with outcomes in patients with suspected CAD really, I think, provides potentially a foundational motivation to study the comparative effectiveness of stress CMR against other modalities that we have for assessment of myocardial ischemia. So, that was a real-world experience. That was a clinical observational registry. I want to take you now to another study called the MR Informed study, and this was a study that was done in Europe, where they was a randomized clinical trial. They took patients with stable angina and at least 2 or more risk factors, or those that had an abnormal treadmill stress test, and they randomized them to either a CMR-guided strategy or to cath with an FFR-guided strategy. And in this clinical trial, the objective was really to look at outcomes. And that's what I'm going to show you the results on here. And again, revascularization of these patients at the time of cath was really guided by FFR. So really they had 2 arms. One was what they defined as a MR-informed arm, which are patients that are randomized to a strategy of undergoing stress CMR, versus an FFR-informed arm, patients that were randomized to a strategy of undergoing invasive angiography with FFR. And the primary endpoint was all-cause mortality, non-fatal MI, or revascularization of the target vessel at the index revascularization procedure. And when they compared the two groups, what they found, in fact, was that the prevalence of abnormality in the MR group that underwent MR, abnormality by CMR was about 42%. Abnormality as far as a positive FFR in the invasive group was 47 or 48%. When they looked at the rate of revascularization, there was a difference. The FFR-informed group had a 42% or 44% rate of revascularization, whereas the CMR guided strategy had a 36% rate of revascularization. But in fact, looking at events over the course of the follow-up duration, which was 1 year, there was really no significant difference in events between either strategy, imaging guided or invasive strategy. So let me move on now to some technical advances in stress perfusion CMR. And a lot of this work has been done by Peter Kellman at the NIH. And he basically recognized that some of the limitations that we have with stress CMR is motion, right? So we typically ask patients to hold their breath, but you can see on the left-hand side, this is typically a 30-minute duration during which, 30-second duration during which when the patient's hyperemic, we're injecting gadolinium contrast very rapidly, and we're following the transit of the gadolinium from the RV. You'll see it next, it comes into the LV myocardium, and then it comes the LV cavity, and then to the LV myocardium itself. And there's obviously some motion that's occurring here because the patient generally can't hold their breath for the full duration. And so, anybody that's done quantitative analysis on these data sets knows the bane of your existence is kind of adjusting your ROIs constantly for each frame because of the motion that can occur. So one of the things that was done was this motion correction algorithm was instituted, where basically these images now are taken from the raw perfusion MR images, but in fact the only difference is it's tried to register the myocardium, the LV cavity, so that to eliminate the motion, so that now when you draw a specific ROI, there really shouldn't be that much in the way of motion that's occurring. So the area you're drawing an ROI in for your first frame should correspond to the same area throughout all of your frames. And you can see this, I think, very nicely if I slow it down and show you this motion corrected image. You can see very nicely now there's really not any motion that makes it challenging to do quantitative analysis on. And then he said, okay, if I'm going to take these motion corrected images, but then do a variety of other processing techniques to these, and I don't want to get into the specific details of this, but essentially be able to actually look at both the arterial input function, which is the transit of contrast within the LV cavity, as well as within the LV myocardium itself, is able to generate then a parametric pixel-wise map that's able to quantify absolute myocardial blood flow. And that's what's shown in this example here. And then if you do that at stress and at rest, now this allows you to essentially look at something called coronary flow reserve as well. And so having developed that initial sequence a few years ago, it was now applied to a series of patients, 15 patients with stable angina who were undergoing coronary angiography, and then they also looked at some healthy volunteers as well. And what they found, in fact, was that when they stratified the patients by those with an FFR greater than 0.8 and those with an FFR less than 0.8, there was fairly good separation using a cutoff of just a little bit less than an absolute myocardial blood flow measure by this technique of 2 milliliters per gram per minute, or using a myocardial perfusion reserve ratio of about 2 to 1. And then I think there was another group of investigators in Europe which took this concept a little bit further and said, well, instead of mapping perfusion as we're giving gadolinium contrast, can we actually just simply look at what the native T1 time of the myocardium is? So essentially, this is a gadolinium-free stress test. They're doing T1 mapping on these patients prior to administration of a stress agent, and then giving adenosine, and then doing T1 mapping again. And what they found, in fact, was that in normal myocardium and remote myocardium, there was a significant change in T1 values when you create hyperemia, but that in ischemic and infarcted myocardium, there was really very little change in T1 time. And again, the concept behind this here is that we know that blood in general is going to have much higher T1 values than myocardial tissue is. And so if there's an increase in the amount of blood within any given region due to hyperemia, then you'd expect that there should be an alteration in the T1 time. And when they took this concept to actually validate it in patients that were undergoing invasive angiography, and they show one example patient here, one who had evidence of stenosis in the right coronary artery. When they measured his T1 time at baseline as well as at follow-up, at baseline, which is here, at stress versus rest, pre-revascularization, there was really not a significant change within the right coronary artery distribution in the T1 time. But then in the stress to rest T1 time after revascularization, which is shown here in the coronary angiogram, you can see now that there was a significant increase in the myocardial T1 time by about 4%. And so they actually proposed then a cutoff that seemed to stratify those with reduced FFR versus those with elevated FFR, and that cutoff seemed to be about a T1 time change of 1.5% from stress and rest. And then let me kind of move on to kind of the last area. So one of the bane of existence for CMR is really the amount of time that it takes to do the imaging. And so what can we do to try to speed up the acquisition? I think that's really where the field is trying to move to in the future, is to have much more rapid, robust imaging acquisition. So there's two strategies that are employed. So let's talk about just garden variety bread and butter cine imaging. One strategy, and again, this is proposed by Peter Kellman at the NIH, was to acquire a series of low-resolution images, free breathing, but then motion correct and rebin them based on the phase of the cardiac cycle to generate then a high-resolution, both temporal and spatial resolution image. And so this is kind of the schematic by which he's trying to do that. I'll show you some example cases. So on the left-hand side, this is a real-time CMR. So this image is taken with no breath holding required, with no ECG gating required, just taking it as a snapshot. And then what's done, is on the middle image here is an example of they took a series of these low-res images, rebin them, motion corrected them, and then generated or reconstructed a high-resolution image as is shown in the middle here. And on the right-hand side is the conventional breath-held segmented cine acquisition, where we typically ask the patients to hold their breath. And so I'll show you a couple of examples that he sent me. So on the left-hand side, this is the standard, kind of gold standard breath-held acquisition. On the right-hand side, this is now a free breathing acquisition that is taken for maybe 10 seconds and then just rebinned accordingly to generate now a high-resolution image. And you can see this works reasonably well, both in the short axis orientation or on the right-hand side here in the two-chamber orientation. Again, this is a breath-held acquisition. This is a free breathing real-time acquisition that's then just reprocessed and rebinned. So using kind of the advances in computer technology that we have to now do a lot of this in a fairly rapid fashion so that these images come offline, within a few seconds of acquisition. So there's another strategy that's also being employed, and this is a slightly different variant, and this is what's called compressed sensing. And so I don't want to get into the weeds of the specific physics behind this, but there's a couple of basic principles here, which is that we can always undersample the images. Now, typically, one simple strategy that's been employed is to say, okay, instead of acquiring every single line of data, because remember, there's a kind of an inherent difference between CMR acquisitions when we're acquiring case space, because every single line of case space somehow contributes to the image detail. So you can actually acquire only half the lines of case space by acquiring every other line and then reconstruct your image. Or you could take this to the extreme and say, I'm only going to acquire 1/10 of the lines of data. But if you do this in a systematic fashion where you acquire every 10th line, it may be problematic. But the idea of this compressed sensing is to undersample, but to do it in kind of a sparse or incoherent manner. And so here's an example of undersampling by twofold, essentially sampling only half of the lines of data. This is an example of undersampling by 1/10 of the line of data. And you can notice, compared to this image here clearly has some degradation in image quality. But the idea behind compressed sensing is to take these principles, and then try to do an iterative reconstruction using, again, computing power to do multiple iterations of this. And by doing that, and then using some other information that you can obtain by multiple different coils, actually try to generate a high resolution image by only sampling a percentage of the actual data, by doing things like regularization, as well as doing multiple iterative reconstructions. And so this compressed sensing technique has been now applied for cine imaging. And there's several publications in the literature within the last 4 or 5 years really showing that, in fact, if you look at something like LV ejection fraction, the values correlate fairly closely with the standard approach as well as with this compressed cine approach where you're doing significant undersampling. And the advantage of this, obviously, is that the acquisition time can be much, much shorter. So I think one potential advantage of this approach versus that rebitting approach that I showed earlier is that approach still requires you to acquire multiple cardiac cycles worth of data, whereas this actually undersamples and actually acquires less data, but then fills in or identifies ways to reconstruct the image without having to resample all those lines of data. So let me kind of wrap up here. And again, I think what I touched on here was really just the tip of the iceberg as far as what the advances are in CMR in the last year, as well as I think what the direction we're heading in. So I think a few things to keep in mind, I think, is that when it comes to myocardial replacement fibrosis, I think we're continuing to get additional insights as well as prognostic implication in a variety of conditions, specifically I think in valvular heart disease and various cardiomyopathies that have not been as well studied in the past. There's technical improvements now in the late gadolinium enhancement technique with now this dark blood delayed enhancement, which I think, again, is going to be optimal for identifying small subendocardial infarcts, as well as especially for looking at the papillary muscles. There's these newer CMR techniques with T1 mapping, which can be used to look at tissue composition within valvular heart disease. And the longer-term objective, I think, with some of these is to say, can we identify a patient with significant valve disease who's remodeling their ventricle at the tissue level more significantly than others, and therefore maybe is someone that could be considered for more early intervention. In stress CMR now, we've got a very large outcome study with nearly 10,000 patients, 1,500 cardiovascular events, showing, in fact, the prognostic significance of an abnormal stress CMR across a wide spectrum of different subgroups of patients. And then in addition to that, I think we've got technical improvements in stress perfusion CMR, which are aimed at reducing the motion that can occur, and furthermore at trying to actually be able to quantify absolute myocardial blood flow in a fairly automated fashion without extensive offline post-processing, as well as this potentially very fascinating approach of looking simply at myocardial T1 times at rest versus with vasodilator agents to identify, without the need for gadolinium contrast, patients that may have abnormalities in myocardial perfusion. And then I think lastly, these approaches to try to accelerate or speed up the imaging and require less patient breath holding to really make it a test that's much easier for patients to tolerate, and I think more importantly, a test that can be done in a more rapid fashion to allow greater throughput. So with that, I will stop and open it up to questions, and thank you for your attention. Any questions? Yes, Jadon?
With the newer technique that you described with using the T1 mapping for stress, SYN, gadolinium, and so forth, how can they, the investigators, differentiate infarct from ischemia if you're not having
Right.
tissue mapping A and B? Both types of tissues are not going to demonstrate a difference.
Right. So no. So that would not be able to distinguish. So again, this was a proof of concept study that was published last year. The idea being simply is that can you look at native T1 times and differentiate normal myocardium versus abnormal myocardium? It's not refined to the point where it can differentiate whether this is ischemic myocardium or whether this is infarcted myocardium. So it doesn't have that ability yet. Yeah. Okay. All right, well, thank you all for your attention.